Hello, my name is Stephen LaFond, and I'll be doing an assessment on Garrett, who's my patient. This assessment is going to encompass neuro, cardiac, chest and lungs, and peripheral vascular. We're going to get right into it. I'm going to check your neuro status. I'm going to ask you 4 questions, just answer appropriately. Can you tell me your name and date of birth?
Garrett Donahue, 2/8/84.
All right. Can you tell me where we are?
Queens Medical Center in Honolulu, Hawaii.
Why not? And can you tell me what today's date is?
July 22nd, 2017.
All right. And can you tell me why we're here?
I'm really sick and I need your assessing.
All right. Hope you're not that sick. So the next we're going to do cranial nerves. The first cranial nerve is olfactory. For the purpose of this video, I'm not going to actually do the assessment, but I'll explain it. I would take a cotton ball, swab it with some fragrance, and then ask the patient to close his eyes, waft it under his nose, and ask him when he smells it.
Smell it.
And the second cranial nerve is optic. For the purpose of this video, I will also not do this assessment as well. But I'll use ophthalmoscope. I'll look into the patient's eyes, check out the retina, then do PERLA, pupils equal reactive to light and accommodation. After that, we would go to a Snellen eye chart and do acuity. The third, fourth, and sixth cranial nerve, which is oculomotor, truncular, and obtusus, is what we're going to assess next. While keeping your head straight, I need you to follow the pencil with your eyes. And this is testing field of vision. And back to center. Wonderful. Alright, the next cranial nerve is cranial nerve 5, which is trigeminal. I'm going to have the patient clench his jaw. Okay, I'm going to move it side to side. So if you just clench your jaw, I'm just going to test the facial muscles. Also, the next one is going to be the soft and sharp test. So if you would just close your eyes, I'm going to you touch it with a sharp object or a soft object, and you just tell me when, which one's which.
No. Hard, soft. No. Hard, soft. Okay.
Alright. The next cranial nerve is cranial nerve 7. This is facial. So I'm going to test your facial muscles. Just give me a smile. Alright. Can you raise your eyebrows? Right on. The next cranial nerve is the acoustic. This is cranial nerve 8. You can either do the whisper test, or you can rub your fingers together, starting from the outside and moving closer until the patient hears you. So close your eyes. I'm going to rub my fingers, and you just let me know when you can hear.
Here. 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 Here.
Wonderful. All right. The cranial nerve 9 is glossopharyngeal, and 10 is vagus. Both of those cranial nerves, I'll be assessing gag reflex and swallow. For the purposes of this video, I will not be testing gag reflex, but what I do is I just take a tongue depressor, have the patient open his mouth, and test the gag reflex. For the swallow reflex, can you give me a swallow? Wonderful. Alright. For the 11th is spinal accessory cranial nerve. I'm going to depress your shoulders. I want you to raise them against resistance. Okay, wonderful. And same with your head. Once I give you resistance, I want you to move your head the opposite way. Wonderful. All right. And the final cranial nerve is cranial nerve 12, and that's the hypoglossal. And for this cranial nerve, I'm going to have the patient stick out your tongue, move it up, down, and side to side. Wonderful. All right, and that is the completion of the neuro assessment. Thank you. Next, I'll be doing a cardiac assessment. This will involve first asking a series of questions to determine the patient's age-related health issues and any cardiac risks. So, I'll ask you a series of questions. You tell me if you have trouble breathing while changing positions.
Oh, no, I don't.
Do you have any chest pain in the past?
No, I don't.
And do you have any persistent cough?
No.
Wonderful. Do you have any past medical history of coronary artery disease?
No.
Any peripheral vascular disease?
No.
Any smoking?
No.
Diabetes?
No.
And so on and so forth. Next, I'm going to take a flashlight and check the patient's jugular venous pulse. This is the anterior to the right in a 30-degree position. There should be no visualization of the jugular venous pulse, which there is not. I'm going to ask the patient now to sit up and take off one part of your gown. This is first going to check the carotid arteries. This is doing it one at a time, and this is anterior to sternocleidomastoid. You'll never do it at the same time because then that will cut off circulation. Great. I am now visually inspecting the chest, looking for symmetry, any heavying, any skin discoloration, which all looks normal. I am now going to check the pericardium. I'm visually inspecting the pericardium, looking for any pulsations, which I don't see any, which is normal. Next, I'm going to check the apical impulse. I'm going to second or mid-clavicular line, 5th intercostal space. I am checking the apical impulse for any normal or abnormal diameter, and abnormal would be greater than 1 centimeter, which this is not. So this is normal. Actually, while I'm holding the apical impulse, I'd like you to take a deep breath and exhale all the way and hold it. All right, that's great. If I can't feel it, or if it's in a different spot, or if it's hard to palpate, I would have the patient roll midway to the left, and that usually helps the examiner. Next, I'll be inspecting the patient's hepatojugular reflex. So if you just lay down for me. So at a 30-degree angle, I will have the patient relax. I'll be looking at the jugular venous pulse while I depress the liver. As I'm depressing the liver, there should be a pulsation on the jugular venous pulse, and then hold that for a few seconds, and when I release, it should be non-visible. Quickly go down. Okay, so I'm going to depress, and you see it pulsating, and a quick run went away. So that is normal. I'm now going to listen with the diaphragm of my stethoscope by holding it firmly to the patient's chest, and going to assess the valves, apical, pulmonic, tricuspid, and mitral. The aortic valve is secondary intercostal space, right sternal border. The pulmonic is second intercostal space, left sternal border. Tricuspid is fourth intercostal space, left sternal border, and mitral is fifth intercostal space, mid-clavicular line. We'll then listen over the apical impulse. This is fifth intercostal space, mid-clavicular line. I'm going to note that if I see any regular, irregular heart sounds, and if I see any irregular, I will note it, possibly write that down in my notes, and do another cardiac evaluation later. Arrhythmias are common, irregularities found in young, rate changes with breathing. I'm now going to identify S1 and S2, which is both heard with the diaphragm. S2 is louder at the base, and S1 is heard loudest at the apex, and S1 correlates with the pulse. So first I'm going to listen to that apical impulse. S1, S2 is present. Any extra heart sounds? S3 is best heard at the apex with the bell of the stethoscope. And then we'll go into murmurs. Murmurs is stenosis narrowing and is an opening problem. Regurgitation, which is insufficiency valve, not closing, right. It is graded on a 1 to 6 scale, in which 4 and above you can also feel a thrill. Most our pathological murmurs are left-sided heart failure. And that is the completion of my cardiac assessment. Thank you very much. The next portion of this assessment is chest and lungs. I have my patient here. I'm going to assess his anterior chest for symmetry of the respiratory excursion, any respiratory effort, pulsations, heavying, shape and symmetry overall. I'm also going to identify the substernal notch and sternal angle. Right there, and the sternal angle looks great. Okay, next I'm going to ask the patient to sit on the side of the bed, and I'm going to do thoracic expansion.
Sorry.
So while placing my hands on the mid to lower back, I'm going to ask the patient to take a deep breath. And this will move my hands symmetrical away from the starting point. And normal is 2 centimeters, which is exactly what he is. That's great. The next, I'm going to do tactile fremitus. If you would, just repeat 99 while I go from the top portion of your back to the lower portion.
99, 99, 99, 99, 99, 99, 99, 99.
Wonderful. I'm going to now do percussion, and which I'm going to do it posteriorly and anteriorly, and note any type of dullness while I do the percussions. Wonderful. And if you just flip over, now I'm going to do it anteriorly.
Just
Yep,
overlook this.
that's fine.
There you go.
Great. I'm now going to do posterior breath sounds. I'm going to listen with the diaphragm of my stethoscope and go from the top portion of the back to the lower portion of the back and ask the patient to take one deep, full breath at each point. So if you just take one deep breath at each point. Wonderful. I'm going to do the same thing anteriorly. So if you just lay on back for me. Wonderful. Take one deep breath. All right, next is vocal resonance. I'm going to take, use my stethoscope, the diaphragm stethoscope, firmly place it on the patient's back and test bronchophony, agophony, and whispered pectoriloquy. All right, so bronchophony, I'm going to ask the patient to state 99. Normally the sounds transmitted through the chest wall are muffled and indistinct. So
99, 99, 99, 99, 99, 99, 99, 99.
Great. Now I'm going to do agophony. I'm going to ask the patient to say E as I, again, move the stethoscope from the upper portion to the lower portion symmetrically.
E, 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 E.
All right. Now I'm going to do the whispered pectoriloquy. I'm going to ask the patient to whisper 1, 2, and 3 while I examine the patient's chest posteriorly. It's starting from the top portion to the bottom portion.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Great, and that is the conclusion of the chest and lungs portion of this assessment. This is the last portion of this assessment is the peripheral vascular section. Going to first ask some related questions to peripheral vascular past medical history. Do you have any history of claudication?
No.
Any edema? Any skin changes?
No.
Any reddening of the skin?
No.
Wonderful. Okay, then I'm going to first assess the carotid arteries via my stethoscope. I'm going to use the bell portion, and I'm going to look for breweries. I will then listen to the other side. I'm now going to go into the upper extremity inspection. I'm looking for color, temperature, texture, skin turgor, any signs of lesions or edema. And then I'll look at the fingers for any clubbing. So I'm just visually inspecting the arm, upper extremities, going down, looking at fingertips for any clubbing, and all looks normal. I'm then going to look at cap refill. This should be less than 2 seconds, which it is. Now I'm going to assess his brachial artery, radial artery, and both are +2, which is a grading scale from 0 to 4, and it's about +2, +3, which is normal. Next, I'm going to move to the lower extremities. I'm looking for the same thing: color, temperature, textures, skin turgor, any lesions, any edema, also hair distribution as well. Atrophy, and then I'm going to take a measuring tape. I'm going to measure both of his calves, and there should be less than a 1 centimeter difference. Next, I'm going to palpate the lower extremities. I'm also going to palpate the pulses. For the purpose of this video, I will not palpate the femoral, but next would be the popliteal, and then your dorsalis pedis and posterior tibialis. All are grade 2, grade 3. For the final, last portion of this, I'm going to do the Holman sign. So I'm going to put pressure on the patient's foot, and if he experiences pain, that would be a positive Holman sign. Any pain? Wonderful. Okay. To test for DBTs, you would do a Trendelenburg leg raise, in which you would tie a tourniquet to the upper thigh of the affected leg and have the patient stand up. If the veins fill up quickly, this represents incompetent valves and a duplex. And then if that was apparent, then we would get an ultrasound to determine. That is the conclusion of the peripheral vascular assessment. To backtrack a little bit, in the neuro portion, I did not complete the position, so I'm going to do that now. If you just close your eyes and I'm going to raise your finger, just tell me if it's high or if it's raised up or down.
Up, down, up, up.
All right, then I would do it the lower extremities, toes.
Up, down, down.
Wonderful. And that's the conclusion of this assessment. Thank you very much for watching.